I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Hegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
A 47-year-old woman with a history of DCIS and stage 1A, a PT1C N0 invasive ductal carcinoma of the left breast, which was ER and PR negative and HER2 positive, with a close anterior margin involved with invasive carcinoma from the lumpectomy. And so the question that we're examining is, should she have additional surgery? If so, what type of surgery is warranted? And so Dr. Jockelson, if you might walk us through some of the images at the time of diagnosis.
Okay, so we have a medial lateral oblique image from her left breast, and a measuring marker that demonstrates that she has microcalcifications that seem to extend from her chest wall to the region of the nipple. And then we know that she had a biopsy, but I don't have any images to demonstrate which part of those calcifications were actually biopsied, so that's one thing that makes it a little harder to assess. And then I'll just quickly talk, the MRI, they claim that they couldn't see any residual enhancement based on the background parenchymal enhancement. It's hard to know whether, I mean, usually if you get really good early subtraction images, you can get that information, but it's hard to know. Maybe this particular patient really did have that problem. With a positive anterior margin, I mean, her calcs go all the way to the region of the nipple, and it may be that they couldn't go. And sometimes you do have an anterior margin, but you're already at the nipple. There's no further room to go. But what I think the first thing I would do is to do a post-lumpectomy mammogram. You want to see if there are residual calcifications in this patient, and also, if there aren't any, that would explain that perhaps they got all of them, except that the next margin was really just the anterior skin.
Perfect. Okay, thank you. So the patient had a stereotactic core biopsy of the left breast calcifications. The pathology demonstrated high-grade ductal carcinoma in situ with a small foci of micropapillary DCIS with a small focus suspicious for invasive carcinoma. The ER and PR was negative, HER2 positive, 3+ by IHC with a FISH ratio of 5.37. And she had negative genetic testing. Her surgery included a left breast seed localized lumpectomy and sentinel lymph node biopsy. The surgical pathology demonstrated a small foci of invasive ductal carcinoma measuring 3 to 4 millimeters or 0.3 to 0.4 centimeters in diameter, located close to the anterior margin within 0.1 centimeters. This was grade 3. There was also noted to be an extensive area of high-grade ductal carcinoma in situ, solid type present and in the anterior margin. No lymph nodes were involved. Again, this was an ER/PR negative, HER2 positive a tumor pathologically staged as a PT1A N0 tumor. So Dr. King, can you comment for us a little bit more about the margin status in this particular patient and how you would think through the approach to this patient?
Sure, thank you. So we do have guidelines now on what comprises a negative margin, both in the setting of invasive cancer with or without DCIS and in the setting of DCIS alone. So here we have a very small invasive cancer with an extensive amount of DCIS, and the anterior margin actually is positive for DCIS, and then the additional margin is close for the invasive cancer. So by either of those guidelines, this patient does require additional consideration for additional surgery to clear that margin if possible. As Dr. Jockelson mentioned, with those extensive calcifications on the preoperative mammogram, it would be important to have a post-excision mammogram prior to returning to the operating room for an attempt at re-excision. She could, in fact, have residual calcifications at another side of the lumpectomy that would need to be removed as well, in addition to dealing with this anterior margin. When you have extensive calcification, some techniques to help ensure complete removal can be bracketing of the area with either seeds or wires, whatever your localization technique is. But in any time when you are pursuing removal of an extensive area of calcifications like that, regardless of your margin status, you should be getting a post-excision mammogram to ensure that you've retrieved all of those calcifications. So here also, as Dr. Jockelson mentioned, the anterior margin, there may not be additional tissue to take at that site. The surgeon would know best based on what they saw intraoperatively. But if that is the case, then it may be that this patient would be a more appropriate candidate for mastectomy. And again, a review of those pre-operative images, really looking at the full extent of those calcifications, getting a post-excision mammogram and seeing what's there. And then, having a discussion between the surgeon and the radiologist and the patient as to what the issues are. Certainly, if she is left with a positive margin, she will be at higher risk of local recurrence. And she has such a good prognosis disease here, small invasive disease. We certainly wouldn't want to leave her at higher risk of local recurrence.
Okay, perfect. Thank you so much for that. Dr. Shaw, do you want to comment about how you would approach adjuvant radiation for this patient, given the margin status and her particular pathology?
Certainly. Obviously, I agree completely with Dr. King. I mean, the first step is to consider either re-excision, or if it's not felt to be appropriate or safe, a mastectomy. Radiation therapy does not negate a positive margin. So no matter how much dose you give, that's not going to fix that. So this is something where we work in close conjunction with our surgical colleagues to try to obtain a negative margin. If she has re-excision and negative margins, I would recommend adjuvant radiation therapy. She's 47 years of age and estrogen negative, so I would only offer her whole breast radiation. I don't believe she's a good candidate for partial breast irradiation. So I would give her 40 gray and 15 fractions to the breast, along with a tumor bed boost of 10 gray and 5 fractions. With this being a left-sided breast cancer, I'd make sure we use some kind of cardiac protecting techniques. So something like deep inspiratory breath hold, or respiratory management, or prone, where women lie on their stomachs, are different techniques that can be used to reduce cardiac dose and therefore the side effects of radiation to the left breast.
Okay, thank you so much. I appreciate that.